Good afternoon, everyone. Welcome to the very first Texas Developmental Screening and Surveillance Echo, brought to you by UT Health San Antonio in collaboration with the Texas Department of State Health Services. My name is Angela Riley, and I will be the facilitator for today's session. A few housekeeping items before we get started. To help with attendance, please enter your full name, affiliation, and email into the chat. Please remember to stay muted unless you are speaking. We encourage using the chat and/or the raise your hand feature to pose questions or share perspectives during our session. If possible, we also encourage everyone to join by video. And as a note, these sessions are being recorded for later distribution. Finally, if you are having connection issues, please privately chat Karen, our Echo IT, for assistance. To ensure privacy, no personal health information is allowed. This includes names, addresses, birth dates, or any other identifiable information. So what is ECHO? ECHO stands for the Extension for Community Healthcare Outcomes. This is a model of learning and guided practice that connects community-based professionals with a multidisciplinary team of subject matter experts to create a network of learners. ECHO was developed by a liver disease specialist to support primary care physicians in delivering life-saving treatment for hepatitis C to underserved patients. And by doing so, we move knowledge and not people and support workforce development and transform community health. ECHO sessions begin with introductions of the team, followed by a brief didactic related to developmental screening. Next, a member of our learning community will present a case with an emphasis on their questions, and then we move on to the discussion. This is intrinsic to the all teach, all learn model of ECHO and the space for you to share your own challenges, strategies, and resources with your learning community. And finally, we end with a summary of key recommendations by the lead specialist. At the end of the session, the ECHO team will send out a post-session survey link that we kindly ask you to complete, as it gives us feedback on how to refine these sessions to better address your priorities. With that, let us move on to introductions. I'll start off with our hub team. Dr. Dorothy Mandel, if you could unmute and introduce yourself, please.
Hi, I'm Dorothy Mandel. I'm an associate professor at UT Health Houston School of Public Health, and I'm at our Austin location. So I'm a developmental psychologist by training and have been working in the field for a while. Not that old, but I'm so happy to be here, and I'm excited to see so many of you all joining us.
Thank you, Dr. Mandel. And Dr. Mandel will be our didactic presenter for today. We'll move on to Andrea Horton.
Hello, I'm Andrea Horton. I'm the Executive Director of Champions for Children in Tyler, Texas, which is in East Texas. We provide training to daycare teachers and also help families when their children have developmental delays. So this is the perfect echo. And I'm so glad to see so many of our local daycare teachers and directors on, and also a lot of my Help Me Grow cohorts. So thanks for coming.
Thank you. And we have Faith Rivera.
Good afternoon, everyone. My name is Faith Rivera, and I am the principal consultant at Alo Civitas Consulting. I'm so excited to be a part of this ECHO, as I've done a lot of work in the state of Texas over the last 6 years in developmental surveillance, screening, and building out of the Help Me Grow model, both in North Texas and supporting statewide expansion. So happy to be here.
Thank you. And we also, today our case presenters, we have two, Andrea Horton, which she already introduced herself, and we also have Kristen Omo. If you could also introduce yourself, Kristen.
Hi, everyone. I'm also with Champions for Children, and I'm going to present a very interesting case study related to COVID, and we'll really kind of delve into trying to distinguish between various disabilities and delays.
Thanks, Kristen. We're happy you're here. Now I'll introduce some of our DSS collaborators. We have Anika Odiegas.
Hi, great to be here. Sorry if you hear a dog barking in the background.
Thanks, Annika. And also Kim Beam.
Good afternoon. I am Kim Beam with the Texas Department of State Health Services. I am the Child and Adolescent Health Group Manager. So we're happy to be able to partner with Echo Hub and all that we do. Angela, do you want me to give the purpose behind it, or are we going to come back and do that later?
You beat me to it. Please go ahead and give
Okay.
us a brief description of the goals for this project, please, Mr.
Sorry
Beam.
about that. So one of our performance measures with our maternal and child health or Title V funding is developmental screening. And so we kind of came together as a team and decided that ECHO would be a really great, effective way to generate movement behind developmental screening. And it's to create a virtual community where people in and around the state of Texas can come together as peers, where they share support, the guidance and feedback, with the overall purpose of the result that our collective understanding of how we disseminate, how we implement best practices, how we work across diverse disciplines for a continuous improvement that continues to expand and make those connections. So that's kind of the overall purpose behind this, with that developmental screening emphasis of sharing best practices and expanding knowledge and reach and resources.
That's wonderful. We're so excited for this project. Thank you, Mr. Beam. So with that, we will go ahead and get started with our didactic presentation. Dr. Mendel, you may take it away. That looks good on our end.
All right. Now I'm unmuted. Sorry. Well, thank you everybody for joining us today. It's so exciting to see so many people interested in this hub, and we're really excited to kick it off. So today we're going to just be on the didactic side. I just want to go over the domains of development, not because I know most of you and all of you actually have extensive training in understanding development and understanding the domains, the different domains of development. But we wanted to kick the hub off by talking about this just as a way to bring us all back together and to kind of recenter us on what it is we're talking about it from a developmental perspective. So there are actually many different domains of development, but usually we only talk about there being 5 domains of development: cognitive domain, the social domain, language and physical domain, and finally the emotional domain. Most of what we talk about in developmental psychology, as well as in other developmental sciences, kind of center along one of these 5 major groups. The reason why these have been broken up into their own domains is because each has their own developmental timeline. You see sub-skills within each of these domains kind of developing differently across the different domains. There's also very distinct emergent properties that happen across each of these domains. So these are the beginning behaviors you see before full-blown skills start being developed and you start seeing those milestones. For me, as somebody who's been trained in neurosciences, also these domains kind of have different biological attributes. So that's one of the other reasons why they get grouped together the way they get grouped together. So I want to talk about each of these domains very quickly and kind of go over some skills that what exists within those domains, as well as some skills that we would see emerging from those domains, really early things that we see emerging from those domains. So cognitive development, this is really what we think about when we think about learning, when we think about reasoning. These are the skills that really help us learn. They help us reason. They importantly help us control our impulses, which you guys on the Child Care Center know a lot about. And they help us individually manage our own behavior. So those things that we normally call executive function, those fall under the cognitive domain. There's the developmental timeline for the development for cognitive development is we really start seeing the emergence of some of this starting at 2 to 4 months, especially along the being able to control our attention. We see that happening pretty early in development. But this domain in particular sees a really, really, really long developmental timeline, with some estimates being between 21 and 24 years before we really set into our adult ways when it comes to cognitive development, especially when it comes to the executive functions. Language development as childcare workers and as people who work in early childhood, it's hard to do anything without thinking about language development because you see the blossoming and the emergence of language. Language falls under two different buckets. The receptive part of language, which is us learning what people say to us, versus the expressive part, and that is what we say and how we express language. Within developmental psychology and language development, receptive language develops differently than expressive language. And also when we're talking about the way they get impacted, receptive language has different things that can impact it rather than expressive language. So from a developmental timeline, receptive language, the development of that really begins at birth. And there's some evidence that it's actually beginning prenatally. Our ability to start learning what is language versus what isn't language, that starts immediately as soon as children start actually hearing voices. So this is one thing I like to tell parents about is it's not happening at the beginning of babbling. It's happening as soon as a baby is born. Expressive language, however, we don't normally see expressive language start until really around about 4 to 6 months when we start to see the beginning of babbling. And that's the beginning timeline for early language development. Interestingly, on the developmental psych side of things, and I looked this up yesterday because I'm like, oh my goodness, we actually don't have an endpoint for language development. Language development we see as a lifelong learning because there gets to a certain point where you have a base language and then learning gets put on top of that timeline. So with language development, I want to go back to those emerging properties that we see and those emerging behaviors that we see, because those emerging behaviors are really what we're looking at when we start wanting to see early identification of language problems. So for receptive language, one of the things that you can really, really see with a baby, in particular, a young baby, is when they start orienting towards your mouth. And that's what we see as the beginning, one of those emergent features of receptive language development. Babies do that whole scan of your face, and I love watching it. Love holding a baby and watching them scan over your face. And then when you start talking, they'll narrow in on your mouth. That is a great emerging property of seeing that the baby is starting to develop a receptive language. The other thing that we see is these babies will start orienting towards the adult who's speaking. So they may orient to other sounds, but there's clear orientation to a speaking adult. As they get a little bit older, 6, 8, 10 months of age, they begin responding to their name and responding to the labels of favorite objects like Baba and their dolls. That's when that is a great sign of emerging receptive language. With expressive language, we tend to see emerging properties beginning with babbling. So those single syllables, the multi-syllables, the things that we are all so excited to hear about. And then also singing fluctuations in the voice. That is, I think, one thing that we don't talk about enough, but babies sometimes will cry with a singing fluctuation and or just coo with a singing fluctuation. And that kind of is helping them develop the ability to start forming those early sounds. On the social development side, these are the skills that really help us lie and deceive. I like putting this on there because as adults, we hate this part of child development. We hate it when children lie to us. We hate it when children start deceiving us. But as I tell everybody, this is also a super exciting time. That's a super exciting thing that you see in early child development, because this is the beginning of understanding theory of mind. It's understanding that you have a different perspective from them is when you start seeing them lie and deceive. So yeah, we have to stop it, but at the same time, you can, in the back of your mind, be woohoo, excited about seeing that skill. This is also understanding other people's perspectives or mental states. I mean, you have to understand somebody's perspective in order to lie to them. Otherwise, you can't deceive them. The other thing that we see coming out, which is so incredibly important, something you guys focus on a lot in social emotional learning, is the ability to share between peers. Developmental timeline on social development. This is something we really start seeing develop around the age of 2 months. And that is with that first smile. That first smile has a lot of motor development behind it, but that first smile is also the beginning of social affiliation and social development. So we may not see a lot of the behaviors that we expect to see, but we do see that important development is starting very early when it comes to social development. So some of the emergent behaviors that we see, eye contact between the baby and the caregiver. When you speak to them, do they orient to your mouth and then they orient back up to your eyes and go back and forth between the two? That is an excellent emergent behavior that we see around social development. The other thing that we see is back and forth play with adults. Serve and return, where the baby starts laughing or crying, you do something to them, that peekaboo, and they're like waiting in anticipation. That's also an excellent emergent behavior that we see around social development. And looking where one person is pointing, that's something that emerges a little bit later in the infancy and toddler period, at the beginning of the toddler, late infancy period. But by looking at where somebody is pointing, you're really getting into that social development of understanding that somebody is trying to orient your attention somewhere else. And there's some great studies that have been done around this about kids won't follow the point of a robot, but they will follow the point of a human, showing it's actually a social, it's a social behavior. And then one of the things we see is responding and orienting to a speaker. And we're going to get back to that in a second. So on the physical and motor development side, this is the fun stuff. This is the growth. This is our bodies getting bigger. This is oftentimes when you look at CDC milestone checklist, it's really focused on physical and motor development, especially early on. But there's a lot more to it than just checking off those milestones. So we also see coordination of body that happens with physical and motor development, issues around standing, walking, talking, all those cool things you guys see that you're like, I gotta tell the parents that this happened today, or maybe you don't tell the parents it's happened today and let the parents see it themselves. But this kind of motor development and physical development is really those early milestones that you guys know so much about. And like I said, there is a lot of emergent behaviors that you guys are already keyed in on seeing, grasping, things about midline crossing. So that means reaching across the body to actually grab something we see a little bit after 3-4 months of development. The ability to roll over, scooting and crawling, grasping things with 2 hands versus 1 hand. Those things that you guys, I know, pay attention to and get excited by. So one of the things that I want to bring back to is that you'll see that in these emergent behaviors, that I actually had emergent behaviors that exist across multiple domains. And that is because we are not a person, an individual with 5 domains, and you see one domain and you see another domain and you see that. You actually see a whole person. And all these domains are actually all mixed up. And that's what we want. We don't want to be like the color monster and separate them out into their own domain. They need to be mixed up. That's what makes us a whole person. So skills may be dominated by a developmental domain, but they are not unique to a developmental domain. All complex skills that we do, whether it is talking, whether it was listening, whether it's some of the executive functions or not, all require more than one developmental domain. So complex skills really are all mixed up. And what I want to say for you guys who are in childcare, you guys are looking at the whole kid. And that is wonderful. You should look at the whole kid. It is not your job to figure out which domain may be impacted by a child. It is your job just to know that something is there. What we're seeing is emergent behaviors not emerging that should be emerging. What you're seeing is a behavior that isn't working quite right. And then you can pass it on and other people can help you figure out, is that a language issue? Is that a motor issue? Is that a social issue? So I want to put that out there, that all of these are mixed up, but it's not your job to unmix them. The other thing I want to put out there is that when you see behaviors not emerge, the thing I hear the most of is saying, well, kids are resilient and kids will catch up. Yes, kids are resilient and kids will catch up if you help them catch up. When we're talking about when we're talking about the development across all of these domains, the development across every single one of these domains requires input from the outside environment. Otherwise, we would have developed them prenatally, but we don't. We develop them postnatally because we need outside environment intervention to be able to develop these domains. And so I also want to leave you with that yes, kids can be resilient. Sometimes miraculously they catch up by themselves, but oftentimes they look resilient because an adult is helping them be resilient and helping them catch up. So I'm going to stop there.
Thank you, Dr. Mendel, for your presentation. This was such a great introduction for the series overall. I'd like to open the floor to our Learning Network. Does anyone have any questions or comments for Dr. Mendel regarding her presentation? No worries, guys. We can also use our discussion portion of the session to go over any questions. But thank you again, Dr. Mendel. So at this time, we'll move on to some brief announcements. Karen, when you have a chance, can you please share those slides? Awesome. Thanks, Karen. So thank you to those who have already completed the pre-evaluation survey sent through email. If you haven't completed it yet, we do request that you complete this short one-time 5-minute survey. This will help us understand more about your learning needs. We'll go ahead and drop that link in the chat as well. Next slide, please. We are offering free TEC PDS certificates for this session. If you would like to request one, please scan this QR code that you see on your screen. We will drop this link in the chat also. And please note that you do have to have a TEC PDS, I'm sure there's a faster way to say that, account before claiming the certificates. You will receive these certificates by email. Next slide, please. Would you like to present a case at our next session? Cases can describe a challenge that you are presently facing with a child in your care. Challenges can be around screening, intervention, referrals, etc. And you do not have to prepare a formal presentation. We will provide you with a simple case form, and you can submit a case using the link in the chat. Next slide, please. And so with that, our next session is actually going to be on Friday, October 18th. Our very own Andrea Horton will be presenting. Please note that only for this session, we will meet on the 3rd Friday of the month. Thanks, Karen. Awesome. So now we'll go ahead and move on to the case presentation for today. Our co-presenters, Andrea and Kristen. Once Karen shares the case, please walk us through it.
All right, thank you guys so much. That was wonderful introduction to developmental milestones in the different developmental domains. So we chose a case that kind of specifically reaches out about the different domains and how they interact with each other. And so, Kristen, I'm going to give you the opportunity to share. Kristen was our child development specialist who was able to work with this family. So we've written up some things, but I know she also has some more wonderful insights about this case.
Okay. Yes, this is a really interesting case. I actually think all my cases are interesting, but this in particular had a lot of different facets as to what might have been going on. So I was asked to come observe this child in September of 21. She had been at the daycare only 3 weeks, and after 1 week, the director was calling me to come observe her. So some of the behaviors were quite grandiose. At the time when I observed her, she was 2 years and 8 months. And as the background says, both her parents are pediatric doctors. One is a pediatrician, the other one works with type 1 diabetic children. And they are Spanish speaking. The parents do speak English, but at the time, the parents and grandparents were living together in New York. And both those doctors were working the emergency room. And so they were right there in the thick of things during that really bad time in New York when so many people were passing away from COVID. So in their home, all 4 of them, the grandparents and the 2 doctors, wore masks from March to October. And the grandparents basically just parked her in front of the TV instead of having reciprocal language in either English or Spanish. And we now know statistically TV can actually be detrimental. And Dr. Mandel kind of touched on it a little bit because language development is a reciprocal social emotional development. And because of the masks, then her receptive was impacted because she couldn't see the lips moving. And so when I went to observe her, she probably only had about 5 words. Now, I did testing. I did testing for ASQ. I also did testing in the Denver 2. Denver 2 is a kind of an older developmental screening that a lot of pediatricians use for years and years. And I did ask her questions in both English and Spanish because I thought, well, with the dual language, maybe it's more a result of she knows more Spanish than English. And so some of the symptoms that were presented was she would rub certain foods on her face. Like I said, maybe 5 words, fleeting eye contact. And so Dr. Mandel touched on this too, because how are you going to learn if you're never looking at somebody's mouth? It's kind of like if you meet an alien, how are you going to learn their language if you can't see how those sounds are being pronounced? And so she didn't want to be touched. She was really good at cognitive stuff like puzzles, shape sorters, very concrete play. No imaginary play. She was still in solitary play. And at this point, she should have been in parallel play for sure. She would not respond to her name. So now we're thinking, possibly hearing issues. But the sad thing is, y'all, the first time they took her out of the apartment was in October. And when she went outside, and felt the wind on her face, she started to cry because she had never felt that inside the apartment. So now we're wondering, okay, we've got several things that could be going on. Is it autism? Is it probably sensory processing disorder with her rubbing food on her face and so forth? It is important to note that about 93% of children with autism also have sensory processing disorder, but not all children with sensory processing disorder have autism. So we had to also make that distinction. So I had to watch her a couple times to see what to do. And a lot of times with dual language families, speech doesn't start to really kick in until about 3, because they're having to learn 2 languages simultaneously. And so there were many things going on. Could it be hearing? So we got the hearing checked. That was okay, let's talk about that briefly. There's the regular sound booth for hearing, which with autistic kids is almost impossible to get a good read. And so then you sometimes want to go to the ABR, auditory brainstem response, but the problem with that hearing test, is they have to be put to sleep for about 15 minutes. And so what ended up happening is, yes, she did get a diagnosis for autism. Yes, she did have sensory processing issues. We got her some intensive speech therapy, and then we got her a shadow to help her learn social cues and to really work on having her be successful in the daycare, because with those other things, she was also hitting and throwing things and so forth. So I did have them go talk to their pediatrician. She was right there at the cusp of, by the time we had observed a couple times, it was really too late to get her into ECI because the 45-day timeline, she only had like 30 days. So ECI is great because it transitions them into the school district for PPCD, but we didn't do that. So we went with private testing, and like I said, speech therapy. Actually, her fine motor was pretty good and her gross motor was pretty good, but she definitely needed some help with the aid and so forth. Super smart, of course, very, very smart. And then I also taught the teacher how to work on certain things, like come play with me, so that she could start to get some social emotional interactions with her peers within the classroom. And she has stayed, she's 5.5 now, y'all. And she stayed at the same daycare and just has flourished with the interventions that we got going. So she's still got quite a ways to go. She's brilliant. She'll probably be a doctor like her parents on down the road. But I do keep up with them, and the director will call and occasionally say, oh, she did this today, and it's really rewarding. Okay, so that was a really fast breakdown of a pretty complex case study. So do you guys have some questions for me?
I just want to say thank you, Kristen, for that wonderful case to really get this echo going. And do you want to come back to present another case? Because that was such a great way to summarize everything. But yes,
Absolutely.
as you
So
mentioned, let's open the floor to discussion. And does anyone have questions for
let me
Kristen?
Thank you so much. Let me
Yeah.
say one more thing. It's always, always good to go into the meeting. So after I do observations, I have a meeting with both the director, the teacher, and the parents. But it's always good to go into those meetings prepared. But you do need to do some testing. So I really recommend Ages and Stages, a really good milestone checklist. Dr. Mandel talked about the domains. So a good checklist will cover those domains. And sometimes they even add in adaptive skills as well. A good checklist should also include red flags, like if there's not reciprocal smiling within the first year of life and so forth. And then you can cut, and you have the parents do the same, because I will say, children often look different at the daycare than they look at home, because at the daycare, they could have 22 two-year-olds in one room for 2 teachers, which is crazy. You should never have 22 two-year-olds in one room, but that's the reality of minimum standards. So going in with the milestone checklist, ages and stages, or even the CDC checklist can be so beneficial, because it's not just you saying, it's providing tried and true testing measures as well, screenings, okay? And then that can help you as far as referrals go. Where do we need to go? Do we need to go to ECI? I'm also a PAT, parent educator. I used to be for Tyler Independent School District. So I love PAT. I also work for ECI, so I love ECI. But yeah, so that you can help them, if they need to go do school testing, private testing, all of that can help you really zone in on how to help those challenging children. And I will say, so many kids are falling through the cracks because pediatricians see them 5-7 minutes and then they're on to the next patient. All right, now questions. Questiones, preguntas, questions?
Thank you, Kristen. Thank you. I may not be working directly in this field, but hearing checklists and having a plan is like music to my ears. And I think that's just the best way to maximize time, especially when it's so limited with specialists and things.
Yeah.
I see Kristen Silva has a hand raised. If you'd like to unmute and share
Yeah.
your question or comments.
Yes, hello. I was wondering if you could share a little bit more. I noticed that you said that they were a dual language family and that speech doesn't really kick in until about 3, which kind of like a little light bulb over my head, because I have a lot of families who are teaching the child both English and Spanish, which, is a really good skill to have, but they're concerned that it's causing a delay and they're like even thinking about stopping it, which is there anything that I could share about, bilingual families, that can help ease their
Yes.
worries?
Yes. So by the way, great name spelled right. Thank you.
Honestly, I was about to say it's hard to find with the 2 eyes.
So yes, so here's the thing. In the first few years of life, we are hardwired to learn any language. So it really is important to be introduced to a second language early, but you should tell the parents that one parent should just speak English and one parent just Spanish. And so that helps a little bit in the development of dual language learning. And be very, instead of saying, este es tu vaso, instead of saying, this is your cup, just say cup, vaso, okay? So that you're bringing it down to really emphasize and with pre-verbal kids, you also sometimes want to work with sounds, like Dr. Mandel talked about. She didn't call it intonation, but basically when they start to do that jabbering, they go da ba ga ba. So with pre-verbal kids, even dual language kids, it's always great to start with animals, animal sounds, and the nouns of the animals, okay? Because those animal sounds are universal, okay? And so, yes. Now, okay, I'm gonna blow some of you away. I see Kayla's on here, Amber's on here. Okay, that means daycare teachers need to learn their numbers from 1 to 10 in Espanol también. Okay, they need to learn their colors. You can go to the Merriam-Webster dictionary, put in red, hit Spanish translation, it pops rojo. It'll even pronounce it for you. So absolutely. I think it's important to, and we're Texas. The Hispanic population now is over 50%. Last time I checked, like 54% or so. And so, yeah, so I think it's important to have that exposure. And, it's also a good idea for teachers to learn to say hello. Even if you have children, hello and goodbye, even if you have children that speak Vietnamese and other language as well.
Can I add a little bit
Yes,
onto this? 'Cause
absolutely.
I do want to emphasize the bilingualism, because it is a common myth that we hear. I do work with CHWs, and it's amazing how much this still exists within society, that it confuses the child to be to learn 2 languages early on. It actually doesn't confuse the child. What confuses the child, so like Kristen, you just said, like, mom speaks one language and dad speaks another language. That is a really good strategy. The other strategy that has shown to be very effective is in one environment, it's one language, and at home, it is a different language. So one of the things that we talk about with especially recent immigrant families is they speak Spanish at home and they leave the English for childcare. That also, it's giving the kid a prediction to know which language is being spoken is really, really incredibly helpful. And there's a lot of good evidence to show that children who are in that environment and their language is actually emerging at the same time as other kids. So I want to emphasize that. Yeah, you may not hear a full sentence out of a dual language learning kid until the age of 3, but they seriously have enough words. It's just our checklists are usually in one language or another language. They're not both languages combined. And if you can checklist, there's research to show if you checklist them in both Spanish and English, they actually have the same number of words. They just have half the words in English and half the words in Spanish.
Yeah.
So I want to emphasize, and you guys, please pass this on to your parents. Dual language exposure early on is awesome. There's all sorts of benefits that it shows, like better executive functioning and better switching and all sorts of great things that come out of dual language learning. So don't let anybody believe that the baby's being confused, because it's usually actually us as adults who are being confused. But the one thing I do want to say, and we do ask this of families, I grew up in El Paso. I know what this is like. We don't do Spanglish. So don't switch in your sentences. Keep your sentences Spanish or full English. And that is a lot harder to do, I think, when you live in Texas. And that's what I tell parents, is that just don't Spanglish on your kid. Spanish or English.
I firmly, Europe, those kids are learning 3 languages sometimes. And it does, I think, in the long run, help with cognitive development, because you're expanding their horizons when they do have 2 languages. When I was teaching preschool, I was teaching the 3-year-olds, and we had to leave the room to go to the bathroom. And I learned French. I grew up in El Paso, so I had Spanish. I took French in high school. I had a German grandma and a Norwegian grandma. And so while we were waiting on turns, we would lay down on the floor and do sit-ups, because I was working on my tummy then. and we'd count 1 to 10 in French, Spanish, German. My Norwegian grandma was like, English only. So it was fun. So the kids were being exposed, those neural connections were staying for those early years instead of getting pruned back. So it just takes them longer. And I think Dr. Mandel's right, their receptive language base, the words they understand, is actually pretty big if you test in both languages. Okay, so
No, this was awesome. I love that dialogue. This is great, Kristen. Thank you. Do we have any other questions or comments from our learning community? And this could also be for Dr. Mandel. I don't know if everyone read the chat, but it could be about her presentation earlier as well.
Angela, can I add something as we're waiting for folks to pop in with other questions?
Please, of course.
So something I think that both Kristen and Dr. Mandel mentioned that I just want to bring back to the forefront is language development, and all of these other pieces really tie back to the relationship component that, you know, this child and other children are learning in the context of relationships, whether it's language, behavior, etc., and finding opportunities within the classroom and within the home to build that really strong adult-child relationship is really important.
okay, I know we threw
Thank you.
a lot out too, but my email is in the chat box, Kristen@championsforchildren.org. I'd be happy to answer any questions through email as well. Okay.
I want to ask a question unless somebody else was going to ask. Rebecca, go ahead. Kristen, and I was wondering if you could talk a little bit about how you help the teacher enrich that environment in the child care center. And I was wondering if you could speak a little bit about what you taught the teacher.
Yes. So because she was doing a lot of rubbing food on her face, I did have the teacher increase sensory activities like shaving cream and whipped cream and getting her hands into, and I will say at first, which was quite interesting, she didn't mind rubbing blackberries all over her face, but at first she wasn't so excited about doing the shaving cream or whipped cream. She just would kind of do, you know, a little bit. And so we had to kind of do gradient synthesization. So we slowly worked her up to being able to fully put her hands in. Now she loved water. So I also told the teacher, well, let her stay for a minute longer in washing her hands. Let her be the last one so she can have a few extra minutes. I did try like a weighted vest. She didn't like the weighted vest so much, but she did like the weighted blanket. And so for nap time, we gave her a weighted blanket. The room did not have enough cognitive toys like puzzle shape sorters and so forth. So we did bolster the room a little bit in the centers. We taught her, so we watched her for a couple of weeks to see which child she was even gravitating towards. There was one child that we finally figured out she would do parallel play with. And so we really worked on strengthening that relationship so we could move her from solitary play to parallel play. And we took her interest, and one of them, interestingly enough, of course, was building. And so we would pair her up with this other child to build things. And then we also taught her to say, come play with me. And so finally, and the director was so happy one day, she called and said, she finally said it to that child. And so, you know, with kids like that, you have to sometimes be very concrete. Her parents started to work on how are you, for introductions and so forth. So we also started with some really light side hugs. And then eventually we got her up to some core compressions to where we could get her to tolerate more of a bear hug for calming purposes. I also do brain gym. So we did some crossing of midlines as well. And I also told the parents things like getting her seamless socks, clothes without tags, because that was becoming an issue because she never wanted to wear her shoes or socks. And then we also tried to use natural lighting rather than fluorescent lighting. And we also worked really hard. If the noise level in the classroom got too loud, then we would try to bring it down, because when the classroom got too loud, she would just melt down. And she didn't want to wear the noise canceling earphones. So, so I taught the teacher to work on 3 techniques of regular voice, outside voice, and whisper voice. So instead of working on inside voice, outside voice, which everybody does, we worked on 3 levels, because there were times when the classroom needed to calm down so that she could function, because she was just getting on sensory overload. So those are a few of the things we talked about and did.
Thank you for sharing that, Kristen. I do see that Irma Bustos in the chat posed a question to you and to Dr. Mendel, and I take the liberty to open it to our other hub team members. Do you all offer trainings for staff?
Yes, I do Zooms. I do conferences throughout the state of Texas. We actually have some online classes. If you go to championsforchildren.org and go to the event training tab, there's a link. Oh, and guess what, guys? I have a free biting class. Woohoo! So if you have toddlers that are biting, guess what? It's completely free. I had someone just yesterday, Andrea, tell me how much that helped her as a parent and helped the teacher on a particular child. So yeah. Dr. Mandel, do you do online trainings or?
We have an online training. Our training is focused mainly with the community health workers. My research is mainly in the healthcare field and doing trainings within healthcare, because as you said, pediatricians only get like 5 minutes. And so we're trying to optimize the 5 minutes the pediatrician gets, but also train nurses and the community health workers and the social workers who are also all in the pediatric office at the time. So we don't have anything for childcare right now, but we are thinking about developing something for childcare in collaboration with CLI, which you guys are all a part of because you guys are logged into, and Angela, tech peds.
Thank you for that.
They have so many fantastic trainings on there, especially around early development. And so CLI has, they are in the Department of Pediatrics at UT Health. And so I tend to push people there. But if there's something specific, always reach out to me. And also, Faith, I want to bring you in because I know you do stuff. Faith, come on.
Okay, I didn't know if that was my cue. Yeah, so I do. Sorry, I was waiting. So yes, to Dr. Mandel's point, I do a lot in the social emotional development space. and as well as family engaged developmental monitoring, which I'll be speaking about in November. I put my email in the chat, and I'm always willing to help find resources if I am not the right fit. But to Dr. Mandel's point, there's a lot of great resources out there, and any one of us, I'm sure, would be happy to point you in the right direction if it's not a direct training or service that we offer.
That is wonderful. Thank you all. And thank you everyone that participated in our discussion and shared resources and input. Faith, since you have the spotlight, if you could please give us a summary of recommendations for this case.
Yes, there was so much great information shared. It was hard to kind of narrow it down. But some of the biggest takeaways that I found from today is really making sure that when you're coming forward to parents, that there's the mentality of you are all a team working together on behalf of this child, on their child. So doing your research, having the proper tools available, and making sure that you are not the only one that is completing these tools, whether it's a screening or a checklist, but that the parents themselves are also in charge of doing that at home as well, to see the different aspects of the child and to really get a full picture of what this child is bringing to the table. Really focusing on how do we build the healthy relationships between the parent and the child, as you, as well as you all as the providers in that child's life. It's okay to bring in outside help. We are not expected to be the experts on all things development, but you have the relationship with these parents, with this child. And so doing your due diligence to be able to bring forth that information, so then you can bring in the outside help to be able to offer the diagnoses or really get to the root of the problem. And then lastly is, we are all interconnected beings, that one issue is often tied to something else. And so getting to the root cause of the real issue or behavior is going to help in the long run, not only to ease probably frustration or time spent on solving the issue, but also really helps build capacity of the parents to be able to best support their child outside of the classroom.
Wow, that was the best summary. That was really great. Thank you, Faith. Thank you so much. And thank you to everyone here that attended today's session. As a reminder, please complete the session survey using the link in the chat. If you would like to present a case at a future session, please email the ECHO admin and we can assist you in the next steps for that. And so with that, we look forward to seeing everyone at the next session on October 18th at 1 p.m. Central Standard Time. Take care, everyone, and have a wonderful weekend. Thank you all.